Kritika, you please switch on your video, ma.
Yes, sir.
Yeah, now it is good. Okay, just wait for Chintamani sir to join.
Okay.
Kanna sir, good evening, sir. Abhay sir, good evening, sir. Ratna ma'am, good evening, ma'am.
Good evening. Only thing I will have to
Good
go
evening,
for the
sir.
IDS
Good
meeting
evening.
at 9.
Oh, okay, sir. Okay, sir. Okay, sir. Kanna sir, good evening, sir.
Yeah, good evening, Dr. Kanagavan.
Good evening, sir. Good evening.
Good evening. Yeah. Dr. Chintamani joining.
Yes, sir. He just arrived home, he said. We'll give another 1 or 2 more minutes, sir.
Okay.
Point.
I think sir is joined. Good evening, sir. Welcome, sir.
Very good evening. Sorry, I was a little held up and delayed. Thank you.
Yes, sir. Thank you for accepting to be with us. And the candidate is already waiting. Sir, we have 2 cases. One is a thyroid, the other one is an epigastric mass. Thyroid case is going to be presented by a student from Government Stanley Medical College, Dr. Kritika. She's a final year postgraduate, MS General Surgery. She works under Professor Anandi and Professor SP Gayatri is her head of the department. So, without much ado, I thank Chintamani sir for joining us this evening. Thank you, sir, for making up for last week's thing. We look forward for your class. And then we have a very eminent faculty who have been traveling with us, Dr. Kanna sir, Abhay sir, Sahai sir, and I think we have Dr. Karnakaran, we have Ratna ma'am. I think we have a lot of galaxy of faculty from across the country and a lot of students on YouTube also. Thank you very much, sir. Dr. Kritika, you can introduce yourself, your unit chief, head of the department, and start your presentation. Good luck.
Thank you, sir. Good evening to one and all present here. I'm Dr. Kritika. I would like to present a case on thyroid swelling under the guidance of Dr. Anandi ma'am and HOD of the department, Gayatri ma'am. May I proceed, sir?
Yeah, please start. Thank you.
History. 48 years old lady, Mrs. X, resident of Tiruvallur district, farmer by occupation, came with complaints of swelling in front of the neck since 7 years.
Please start, Kana. You are good to go.
Patient noticed swelling in front of the neck, present for the past 7 years, insidious in onset, progressive in nature, initially about 2 cross 2 centimeter in size, now progressed to the current size of 5 cross 3 centimeter in the past 1 year. It is not associated with pressure symptoms, not associated with symptoms of hyperthyroidism or hypothyroidism, not associated pain or fever or any other swellings in the neck, and no symptoms suggestive of distant metastasis. Comorbid history. Not a known case of type 2 diabetes mellitus, systemic hypertension, bronchial asthma, or coronary artery disease. Past history. History of taking medication for thyroid dysfunction every day, early morning, in empty stomach, most probably for hypothyroidism, tablet thyroxine for 1 year. Discontinued 7 years back, reports of which are not available. No history of similar complaints in past. No history of irradiation in childhood. History of hysterectomy done 5 years back due to abnormal uterine bleeding, details which are not available. Menstrual history. Patient attained menarche 15 years back. History hysterectomy done 5 years ago. Marital history married 20 years ago, non-consanguineous marriage. Obstetric history, para 3, live 3. Personal history. Patient consumes both vegetarian and non-vegetarian diet. No history of intake of goitrogens like kale, cabbage, or leaf. Consumes iodized salt. Sleep and appetite normal. Bowel and bladder habits are normal. No history of any substance abuse. Patient doesn't live in nuclear exposure zone. Drug history. History of consumption of tablet thyroxine for 1 year and discontinued. Reports not available. No history of intake of goitrogenic medication. Family history, no history suggestive of similar illness in the family. Summary: 48 years old female patient with a painless swelling in the anterior aspect of the neck since 7 years, with no evidence of pressure symptoms and no features of suggestive of hypothyroidism or malignancy.
Very nice, very good history, Dr. Kritika. And the highlights of your history include mentioning about the general symptoms related to thyroid disorders, including bowel, bladder disturbances, menstrual history, etc. And what I especially liked was your mention of not living or getting exposed in the nuclear prone areas, because that has got significance. So rather than taking history of radiation, which is very, very general. But there's one thing before others can ask you questions. The only one thing I would like to suggest, and maybe if you accept it, it'll be good for you. The term like no similar illness in the past, no similar illness in the family. These are very casual statements because we don't know what the illness is, and certainly the patient doesn't know. So you could be more specific. So what is that similar illness you were looking for in the patient, which you were looking for also in the family?
So previous is your thyroid swelling, so, or the
So you
family history of
can be
any
direct. Yeah, so you can be direct about it. There's nothing camouflaged or hidden in most cases when you're presenting as a postgraduate, and especially when you're such a bright student as you are with the kind of mentors you have. So I would suggest to all the other students also, there's no history of similar illness in the family, I'm sorry. No history of similar illness in the family. No, similar means nothing. We don't know what the illness is right now, and we talk about, or the patient certainly doesn't know. The other thing you mentioned was relating to the obstetrics history. Could you elaborate more on that? I don't want to take a lot of time out of a wonderful history that you presented.
She has
What is,
3 children, so all 3 are normal vaginal deliveries. Then
so,
permanent sterilization
what?
was
Great. This was normal. So, what is it that you were looking for? What did you have in mind when you were asking this history?
selected.
Or is it just another history you will take in any lady who presents with any problem, which is also correct, but anything specific to a patient with thyroid disorder where this history would attain a lot of significance?
Maybe menstrual disturb irregularities or irregular menstrual cycles or oligomenorrhea or hypomenorrhea.
No, that's menstrual. I mean, that you already mentioned menstruation. Menstrual history you have described. I'll ask you that also. There's nothing. What exactly can go wrong if somebody is hyperthyroid in obstetrics history? What exactly can happen? So you take that history with something in your mind. Every history has got a reason why you're asking. If you don't know, it's okay. What can happen to a lady who is trying to get pregnant or becomes, I mean, is actually pregnant, but she's hypothyroid or she's thyrotoxic? And what about the menstrual history in these patients?
She had a regular menstrual cycle,
You
so
mentioned that. What did you have in mind when you were asking? What can go wrong? What happens to the menstrual periods in patients with thyrotoxicosis?
thyrotoxicosis patients may never have oligomenorrhea, so,
And in
and
hypothyroidism?
they have menorrhagia.
And which of the two will have polymenorrhea?
Uh, Polymenorrhea is seen in hypothyroidism.
See, actually, the reason why you've taken this history is for a very obvious disease in mind or a diagnosis in mind. So it could not be a casual history. Just like that, if you ask a patient or a lady, I must take this history, married for last 20 years, how is that relevant for your case? It's a correct history. I'm not saying don't take it. And what's the significance of non-consanguineous marriage? Both things you need to explain because what you're asking in history, you must be able to explain.
consanguinity, like certain syndromes can be autosomal dominant or familial syndromes can be there, sir.
So
Like
which
N
thyroid
syndrome,
disorder can fall into that category?
medullary carcinoma of thyroid is familial, sir.
Okay,
Followed by
and
dysharmonogenetic goiters.
absolutely correct. For the journal, I was just trying to understand if you have a direction in what you were trying to find out. I'm sure others will ask you more questions. If I go on talking, then that won't be fair. Dr. Ratna, any question?
Yeah, yes. Kirutika, you mentioned there are no pressure symptoms and no features suggestive of malignancy. Can you highlight the difference between the two when you asked this question?
Pressure symptoms indicate in case of a large goiter causing compression can have present with dyspnea or dysphagia, ma'am. And if there's a posterior enlargement, it may could compressor nerves, nerve causing hoarseness of voice. Symptoms suggestive of distant metastasis like a
No,
common case of
you've written malignancy. Malignancy could mean features related to the primary or to the secondary. Or did you ask only for features of metastasis?
malignancy for primary also, ma'am. Pressure
So
symptoms can
what
be
I
there
wanted to
for
highlight was that you need to take history of infiltrative symptoms also, like voice change and all, which will happen due to the primary tumor.
primary.
And there are some contentious statements in what you have written, like sir already highlighted about menstrual history. You've written no features of hypo or hyperthyroidism. At the same time, you've written that 1 year ago, patient took medication for some thyroid disease. That means she had some features of hypo or hyperthyroidism, no, for which she took. And plus, obstetric history is also suggestive of the fact that she did not have a functionally normal thyroid. So this contentious statement you should be able to avoid. Yeah.
Okay.
So,
Right.
so back to you.
See,
So why did this patient has come at this time? You know, she has got a swelling for 7 years, but why she has come now? So what is the chief complaint in that?
So she has progressive swelling which has increased in size in the past 1 year. So it was initially a size of 2 cross 2
What
centimeter.
happened in the recent past? Something change was there in the recent past that she came to the hospital?
She complained mostly of cosmetics. Initially it was smaller, didn't bother her, but now the size has been increasing in the for the past 1 year. So she had comes to us.
Okay, and you said it is since 7 years. That is not a good word for that, no? You should use the far. Here you have written the far, but at places you have written since 7 years.
Kritika, you understand the difference between for and since that Professor Khanna was trying to tell you. You may take this home, but if you don't understand, you'll forget it day after tomorrow. So what is for? Why should you write for rather than since? When you mention since, it is a fixed time and date, which you cannot comment on. So therefore, we use the term for the past so many years, for the last 2 hours, or 3 or 4, 5 hours. So be careful about a lot of statements. There are many. Can you just run through your presenting complaints and other slides in quickly? We are not trying to bother you. We've done a good job. Start from the first slide, if you can, please. This is fine. Next slide. Now you're presenting complaint, but that's why he was asking you. I was just trying to highlight that point which Dr. Khanna was mentioning. Something that has been there for 7 years, then something must bring her to the hospital. And that rapid increase in size or increase in size, you should highlight more for us to understand that this is what brought the patient to the hospital. Next slide. Next. This is past 7 years, is okay. Sorry, you were there, no? Previous slide. What is happening? Just stay here, don't worry. Initially about 22 and now progress to, can you stay there, please? Thank you. And it is doubled, nearly doubled in its size in last 7 years. So this is probably brought in. What do you mean by progressive in nature?
It has increased in size, sir.
So we talk about onset, progress, and basically our onset is insidious. And is the progress rapid or it is also gradual?
It has been gradual in the past 1 year.
There's no such term as progressive in nature, right? So you will use that term. Next slide, please. I'm just summing it up for what everybody has already said. Next, please. Am I audible to you? Yeah.
Yes, sir.
So pressure symptoms are very vague, and that was very rightly brought out. Pressure symptoms would happen only to large goiters, as you yourself said. Your goiter is not so large, but they can still happen. And pressure symptoms are not features of malignancy, so don't get confused. Pressure symptoms can happen due to weight and the pressure, and then patient will have features like orthopnea, etc. Understandable. But infiltrative features will be the features of malignancy. Very large goiters also may not produce hoarseness because they don't cause infiltration. Infiltration is a sign of cancer, which is why hoarseness becomes important. And hoarseness for hypothyroidism also becomes important. Your patient is taking the drugs. It's not associated with pain, fever, so there are no inflammatory features. Next slide. This has been covered. So I'm glad you didn't put it down as past history, which usually happens. So diabetes, mellitus, hypertension, they are not past history. Once they are there mostly. Next slide. Can you move to the next? Yeah. Now, this is a very important history, which is what makes it significant. When you say no history of irradiation in childhood, so what did you ask her? She won't be able to explain.
So generally, the childhood lymphomas, we give mantle radiation.
That's brilliant. You're right. Absolutely correct. Now, what did you ask? The patient may not be able to answer. So, did you receive any therapy in the form of radiations for some disease? And low dose radiations, which cause thyroid cancers, are not given these days. So, the exposure to radiation, the one that you mentioned later on, is more relevant. Hysterectomy 5 years back due to abnormal uterine bleeding. Is it connected or not connected to the disease?
Might not be connected. So maybe hypothyroidism could have caused her menorrhagia leading to it, but she was not evaluated for it and didn't cause much of a trouble last symptom.
Brilliant. Next slide. Next, I think it is repeating. This we have already discussed, so I won't bother you with that. Think about stillbirths, think about abortions, miscarriages, which are relevant in taking the obstetrics history. Obstetrics history is not just run of the mill, especially in thyroid disorders, breast cancers. So it has got some special relevance also in a particular disease. So accordingly, you should, use it. Next slide. I think we have covered this, so I won't waste your time. We can. This also has been covered extensively. Patient is already on thyroxine. And what did you mention in the family history? I've already told you. So you will be specific. So what exactly did you ask her? Does anyone else in the family have swelling in front of the neck or something different?
Swelling in front of the neck, sir, or any family history of malignancies relating to this.
Is it mentioned here, madam? It's not mentioned. That is more relevant to us, no? So rather than saying no history of similar illness in the family, this illness we don't know and we are asking for similar in the family. So it becomes easier. We're just trying to guide you into doing a better job of what you've already done very well. Next slide. Now that summary everybody has heard. So I think we can move on.
No, I've got a few questions, sir.
Okay, you're there. I didn't see you only, Dr. Sai. Yes.
Good evening. Good evening. Look, Dr. Muthakrishnan, most of these thyroid diseases are autoimmune. Even Graves is an autoimmune. They can run in the families, right? Even thyroiditis is an autoimmune condition. So you have to take a more detailed family history about thyroiditis, about Graves. Do you get me? Also, there's a term called postpartum thyroiditis, which is a temporary inflammatory system condition where the patient can have features of hyperthyroidism. You get me? So family history, even malignancy.
She mentioned
rightly pointed out medullary carcinoma of the thyroid.
Perfect point.
So thyroid, there are a lot of conditions which run in the family. Just plain goiter also runs in the family if everyone's consuming certain kind of food. Okay, so family history is important.
Very rightly brought out, Dr. Kritika. Family history, when you talk about family history, is with some very particular familial disorder in mind, as you brought out. you got to be more specific rather than similar illness, which is a casual, vague statement. It doesn't really help. I think we won't get back into the same thing again and again. If there is any other point that...
Yeah, I have a small point to make, sir, because she said that there is a progressive increase in size to a size of 5 centimeter from 2 centimeter. For a swelling which has been stable for 2 centimeters becomes more than double its size in 1 year, I feel should be regarded as a sudden increase in size over a period of 1 year.
We covered that. That's what we told her.
But this should be sudden increase in size rather than a progressively increasing swelling. So,
right. So can we move to examination? We'll again ask those questions so that we can finish on time. Dr. Muthu Krishnan, please proceed to examination. Please note down the questions relating to history. We'll come back to those again.
Examination, general examination. Patient was examined in a well-lit room with adequate exposure in sitting position after taking due consent. Patient is moderately built and adequately nourished. Patient's conscious, oriented, afebrile, hydration fair. BMI is 23. No pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy or peel edema. There are no signs suggestive of hyperthyroidism, such as exophthalmos, fine tremors, fasciculations in tongue. No signs suggestive of hypothyroidism, such as dry skin, mask-like face, mixed edema. Vitals, pulse rate 86 beats per minute with normal volume and regular rhythm. Blood pressure 110/70 millimeters of mercury measured in left arm with patient in sitting position. Saturation is 98% room air. Respiratory rate is 16 breaths per minute. Temperature is 98 degrees Fahrenheit. Examination of neck. After obtaining a verbal consent, patient examined in a well-lit room in sitting position, and after providing adequate privacy, neck is adequately exposed and examined from front and back. Inspection. A single ovoid swelling of size approximately 4 x 3 centimeter in the anterior aspect of neck in the right side. Surface appears smooth. Borders are well defined. Skin over the swelling is normal. Extent. Superiorly up to the level of upper border of thyroid cartilage. Inferiorly 1 centimeter above suprasternal notch. Medially it crosses the midline 1 centimeter towards the left. Laterally up to anterior border of right sternocleidomastoid. Swelling moves upward with deglutition. Lower border is C. Trachea to be neck. No dilated veins in the neck. Palpation. No warmth or local rise in temperature. No tenderness. Inspectory findings are confirmed by palpation. A 5 x 3 centimeter swelling in the anterior aspect of neck. Ovoid in shape, mainly involving the right side with well-defined borders. Firm in consistency. Surface is smooth. Swelling is mobile. Swelling is deep to deep cervical fascia. No nodularity felt. Rest of the thyroid glands not palpable. Swelling moves upward with deglutition. Able to palpate the lower border of the swelling. No thrill present. No other swelling present in neck. Carotid pulsations felt at the normal position. Trachea is at midline. Auscultation, no bruit. Other system examination. CVS S1 is to her, no murmur. RS normal vesicular breath sounds heard. CNS no focal neurological deficit. Her abdomen soft, bowel sounds heard. Oral cavity is normal. Carotid pulsations felt at normal position. Trachea is at midline. Auscultation is no bruit. Summary. 48 years old lady with 5 x 3 centimeter ovoid, firm, non-tender swelling in right lobe of thyroid with smooth surface and well-defined borders without any evidence of pressure symptoms or hyperthyroidism or hypothyroidism. Most probably a solitary nodule of thyroid from right lobe.
Right. So many things are very repetitive. So we'll start from the first slide. So that's easier to handle. Well, I personally don't have an issue with which pattern you follow, but some people insist. And it's always good to hear everybody's view. They'll come out with it themselves. So when you're mentioning, you examine the patient in a well-lit room with adequate exposure in a sitting position after taking due consent, whether informed or implied, both. Informed mostly. Patient is moderately built and adequately nourished, conscious, oriented, afebrile, hydration is fair, and BMI is good. No pallor, clubbing, colonica, cyanosis, icterus. You already committed on none of these being present, which is perfect, so that we don't repeat it later. Next slide. Now, I have no problem if you mention no signs of suggestive or hypothyroidism. You can mention if they're visible. You don't keep them till the end when you're describing the thyroid examination. Fine tremors, fasciculations in tongue, you better but then know how to do it. How did you check for fasciculations in the tongue, Dr. Kiritika?
So we ask the patient to open the mouth and keep the tongue protrude in such a way that the tongue remains on the lower border of the lower lips. And we look for the fasciculations and tongue fine movements.
Have you really done it? And do you know that it's an absolutely insensitive test? If the fine tremors are absent, you look for tongue tremors or fasciculation. It's like asking for too much. Most of us know these are given in the books, but then you better know how to demonstrate it. Correct? It is
Yes.
not the classical way, as you mentioned. I'll talk about it later. Now, no signs suggestive of hypothyroidism. Perfect. No problem. I'm happy. Now, be prepared to answer you already mentioned no edema, nothing, and you already cleared that. So it's perfectly okay mentioning them here so that you can be, you're able to highlight these points for examiner to ask you questions. So they'll be asking a lot of questions pertaining to this. Next slide. Next slide, please. Now here, unlike in most other situations, pulse becomes very important. And don't start by writing pulse rate. Pulse has to be described in details in all thyroid cases. The rate, rhythm, volume, character, vessel wall, and synchronicity with other pulses becomes important. What kind of a pulse you get in thyrotoxicosis?
Thyrotoxicosis, there will be tachycardia, sir, and
Tachycardia is all right.
irregular
That's a
is a irregular pulse, sir, and patient may develop atrial fibrillation causing irregular pulse rate, sir, when
That's
missed
not correct. So I just triggered one point and so many things came out, and a lot of them are not really happening in most cases. You get what is called water hammer pulse. You'd certainly get the volume is high. So it is important to highlight these features here. In thyroid, it's relevant. Otherwise, it's relevant in all cases, like a abdominal case, it may not be relevant. Blood pressure, SpO2, all that stuff is okay. And patient with afebrile is fine. Next slide. Now you're examining the neck, which you did by sitting in front of the patient at the same level. It has to be described. And you describe the swelling 4 into 3 centimeter anterior aspect of neck on the right side. Surface smooth, borders are well defined, and you're going to repeat it again in palpation. I'll show you when you go ahead. Next slide. Postgraduate examination is slightly different, and this extent that you have described, doctor, is actually the thyroid fossa. So there is a visible swelling of the size approximately 3 into 4 centimeters lying in the thyroid fossa. Moving on deglutition, the lower border can be seen and the thyroid cartilage is otherwise clinically visible and there's no displacement of trachea. It sums up the thing and you get a question from the examiner as to what are the boundaries of thyroid fossa. Exactly what you have written here. So always hold that back so that when you throw it to the examiner, he's got a question for you and you got an answer for that question. So it is unnecessary to go around beating around the bush. Next slide. I think you've described this. Now, swelling moves on deglutition. All swellings, everything moves upwards on deglutition except food. So don't try to mention this upward movement. And I'm glad you didn't mention not moving on protrusion of tongue because that is not relevant here. Perfectly done. Lower border is clearly visible. Is seen or clearly visible? Better. Trachea appears to be midline. I've already covered that in one sentence, which is what I was trying to highlight. No dilated veins in the neck. And you expose the patient right up to the upper part of the chest. So you're comfortable in ruling out any kind of a pressure symptoms or a superior vena cava syndrome. Next slide. I'm trying to rush through it so that others can ask you. Now, a lot of it will get repeated. The size there, size here, doesn't make any sense. This is the final size. So you can't be saying on inspection it was 3 into 4, now on palpation it is 5 into 3. You do palpation to confirm what you found on inspection, and you mention inspectory findings are confirmed by palpation. So one size, one finding is enough. You do it basically, that's a division for convenience. That's not how you describe it. It's more for how you do it rather than how you describe it. When you're describing it, it should be coming out straight away. This is the size, moves on deglutition. This is the consistency, surface is smooth. Don't waste time at all. Swelling is mobile. Next slide. Now, swelling is deep to deep fascia. What do you? I know we talk about what is the plane of the swelling. Now, what is the relevance of this statement now? Is the swelling moving on deglutition?
Yes.
How does it move on deglutition, doctor?
The pretracheal fascia splits and encloses the thyroid gland, and it's thickened the posteriorly, medially, it forms the Berry's ligament. So the Berry's ligaments attached to the cricoid cartilage. So when during swallowing, when the laryngeal apparatus moves up,
That's not enough. Then
the
it moves up further the inferior constrictor, which is attached. So on swallowing, it goes up. And therefore, large coitus, when people talk about dysphagia, that's an incorrect statement. It's discomfort on swallowing because of the weight that has to be lifted each time by our, ligaments. So swelling is obviously deep to deep fascia when you say it's a thyroid swelling. So it doesn't need to be described again. That's a better way to describe in a postgraduate examination. So this is irrelevant here, unless somebody is fussy about asking. And if you run into a fossil, say that it is deep to deep fascia because it is already moving on deglutition. I have no confusion. Otherwise, how did you arrive at this? How did you find out it's deep to deep fascia?
So on contracting the sternocleidomastoid muscle, turning the head and contracting the sternocleidomastoid muscle.
Sir, can I come in 1 minute?
Sorry?
I am Dr. Abhay Darli.
Yes, you can come in.
Sir, the problem is the candidate is not able to answer. You are only asking her questions where she has no answers. So you have to go slow on it.
Providing the answers at the same time so that we cover more, Dr. Dalvi, in the same time, no? Your point
Yeah,
is...
but it becomes an oration.
Yes, Dr. Kiritika, let's carry on. So I am trying to give you a bird eye view of what you presented, and then there are going to be questions. Did you understand so far what I told you?
Yes, sir.
You are able to hear me?
Yes, sir.
Okay.
Yes, sir.
Now you can move to the next slide.
Yes, sir.
I think there'll be questions pertaining to all those findings. I was just trying to tell you, when I'm asking a question, I'm also answering. You should know how you should be doing it next time. That's what is the purpose of these classes actually. When you say carotid pulsation is felt at the normal position, what exactly do you mean by that? Where is that position?
Carotid pulsations are felt opposite the chasagnac the tubercle of the C6 vertebra and the chasagnac tubercle, which is palpated the upper border of the thyroid cartilage on the anterior border of the sternocleidomastoid.
Brilliant. So, and it is usually where you feel it against a bone, and what you're feeling is not the you're not feeling the external or the internal carotid. You're feeling the common carotid. Next slide before we come to the end of it, and then they'll ask you questions. Next. Now that's a summary, and finally the size becomes 5 into 3 centimeters. Ovoid, firm, non-tender, right lobe with smooth surface and well-defined borders without any evidence of pressure symptoms or hyper or hypothyroidism, most probably a solitary thyroid nodule. Yes, Dr. Ratna, any questions?
Yeah, yes, a couple of questions actually.
Yeah, 1 minute.
You said that
1 minute, if I may.
Yeah,
for the benefit of others, I was trying to put it in perspective so that when discussion happens, it doesn't become a question-answer session. Yes, Dr. Ratna.
Yeah. So you said that the pulse rate is 86. Do you think it is tachycardia or a normal pulse rate?
Normal pulse rate.
What is the normal pulse rate?
60 to 100 is said to be normal.
60 to 100. So maybe I stand corrected. I would take it as 60 to 80. And if you write anything more than that, you need to clarify, is it due to anxiety? Is it due to hyperthyroidism? Right? Then you should, once you write anything above 80, then you should also talk about whether the palms were wet, dry, cold, or what, right? What is the consistency of the swelling? I did not find it in your presentation.
Mention firm.
Firm in consistency.
Firm in consistency, right? What is thyroid paradox?
Cystic swellings are firmer and solid swellings are softer.
So malignant swellings may be soft, while benign swellings like a cyst may be hard. What is Paget's test?
Paget's test is a test used to
Hello?
palpate smaller
Yeah.
swellings, ma'am, where we hold the swelling in between the two fingers and compress on the top, ma'am.
This is to rule out whether it's a cystic swelling or not. So even if it's a firm or a hard swelling, it can be cystic. So in small swellings, you can do that. Now you said that the swelling is going across the midline to the left side. Now isthmus of the swelling, isthmus of thyroid is fixed. In spite of the fact it is going to the other side, in your diagnosis, you're calling it a solitary thyroid swelling. Can you explain that? You mean to say the right lobe is going to the left side with the isthmus in place? Again, I find this to be a contentious statement.
The swelling has enlarged, ma'am, causing it to a slightly cross the midline.
Right. So you mean to say the right lobe has displaced the isthmus and has gone to the left side?
It has enlarged, causing the midline. Cross the isthmus.
And then you said that trachea is probably central. Is it central? Is it not central? Or is the right lobe enlarged and pushing it, and right lobe is moving to the left side after displacing the trachea? What is trail sign?
Trail signs the prominence of the sternocleidomastoid in the side of deviation of the trachea.
So we assume that you have done all those inspectory and palpatory findings to say that trachea is central. If trachea is central, how can this swelling be a solitary thyroid nodule if it is going across the midline to the other side? So,
All right.
so I mean, maybe you stand corrected here. You need to see a patient to be able to say that. I think maybe others can comment on it. That's it. So.
No. But the point is, whenever you ask a question, please answer that so that she goes back learning from it. So, what would you want her to do in that situation? Because that's what the class is about. It's not an exam. So, yeah. So could you tell her how should she describe it?
So what I mean to say is that, to my mind, she needs to repeat her clinical examination, because the swelling in the right lobe without displacing the trachea cannot go to the left side. I stand corrected unless and until only the upper part is involved, upper part is going. Thyroid doesn't have a treetop mobility like that.
No, not
treetop. So I think you need to repeat your clinical examination again. If other senior doctors have some more experience to share, maybe they can.
Yeah. Yes, Dr. Dalvi, you raised your hand.
Yes. So let us see this patient's history. It's a 7-year-old swelling, which suddenly from 2 centimeters has gone out to 5 centimeters. It has not displaced the trachea. That is what the candidate says. Do you agree, Krutika?
Yes, sir.
Yeah, say loudly. Don't
Yes,
have
sir.
to be. I'm not a wicked examiner. So it has increased. There is a concern in the patient that this is increasing and requires investigations to come to a diagnosis whether she requires some sort of intervention. We have not yet, I think, gone into investigations, but whatever it is, if investigations show benign, what would be your approach to this patient? That is the question that I want to ask you. Now, regarding your history, can you go back to the history and examination of this patient, please? So, okay, fine. Summary on history. painless swelling, 7 years, no evidence of pressure symptoms, no evidence features of suggestive of hypothyroidism. This patient was taking some medications for thyroid and omitted 1 year back and still is happy, correct?
Yes, sir.
Loudly, loudly.
Yes, sir.
Yeah, thank you. So go ahead.
Sorry.
I think there are two types of progression which is there. One is called a rapid progression and another is called a sudden progression. Sudden increase or the rapid increase. What is the difference between these two terms?
Sudden increase in seen in case of hemorrhage, sir, is acute condition.
Yeah.
Whereas rapid progression could be seen in a malignancy over the past of 1 month, sir.
Yeah, so rapid increase is not in days, and it is in the usually the weeks and the months.
Weeks and
So a
months.
sudden increase in within days, your hours.
And you
Okay.
need to distinguish the two, very correctly mentioned, because it doesn't, we can't leave it loose-ended. You've got a swelling for last 7 years. It must have been gradually increasing. She was not measuring it every day. And if it is increased in last 1 year to almost double its size, then it will be probably on the faster side. But you don't know. It was never examined any time in the last few years. Uh, Before we come to the workup, etc., can always come later. It's a clinical examination. So that is where Dr. Ratna was right. Actually, you need to examine it. And unfortunately, in all these presentations, we can't really see the patient and correct if there is anything. But generally speaking, if you show that picture, your swelling doesn't look frightening or very large. And the patient doesn't have a very big neck also or very thick neck. So it may be that patient doesn't have that kind of a size which can push the trachea to the left side. But when you mention that it is crossing over and the isthmus is also involved, then that question automatically becomes valid. So I'm just trying to explain that question to you. So do understand what the examiner is trying to ask you, right? And these classes are a blend of teaching. There's no examination happening. So examination is a different ball game. Here we also need to tell you as to what is it that you were, asked and what is the answer to that. Yes, Professor Khanna, you were saying something.
What is the relation of sternocleidomastoid to the thyroid swelling?
The swelling is always present behind the thyroid sternocleidomastoid. So even if it enlarges, it is always present deep to deep fissure always behind the sternocleidomastoid.
Yeah, you can blindly say, even if how
Yes.
big is the thyroid is there, you can blindly say it is deep to the sternocleidomastoid. It will probably never come superficial to the sternocleidomastoid. What
Valid.
are the various ways to tell the trachea? That where is the trachea?
Inspection, we can find the tracheal position. The trice sign. So if this trice sign is negative, it's said to be midline. If it's deviated, there's a prominence of the
Okay, so one
sternocleidomastoid.
is inspection, yes.
In palpation, we can do 3-finger test where we keep the index and ring finger and
Yes,
the
okay.
2 edges of
Any
the
other way
trachea.
to tell about the trachea?
We can auscultate for the trachea. So if it's in the midline, trachea can be auscultated.
Good, yeah. You have auscultated the thyroid here, isn't? Where did you do the auscultation?
It's auscultated at the superior pole.
You said the auscultation? Nobody heard.
Can you mute yourself, please?
Auscultated for the bruit in the superior pole.
So where did you auscultate?
Auscultate for bruit in the superior pole of the thyroid.
Why not on the inferior pole?
The superior pole is where the superior thyroid artery enters as a whole and it divides inside the thyroid gland. So it is anteriorly placed and it is also the first branch of the external carotid artery. So it has got a higher vascularity. So generally, fluid is well over there. And the inferior thyroid artery doesn't come the superior pole, but it comes laterally, sir, and it also branches before it enters. So any bruise is not heard well in the day.
So what is the vessel at the inferior pole?
Inferior thyroid vein is present.
Good.
Very well answered. Actually, inferior thyroid artery has nothing but thyroid until it has reached there, divides into branches, comes from behind the carotid. So you won't be able to find it out.
What are the various carotids you can feel in
If
the
I
neck?
have to ask you a question about McGregor's anatomy, can you tell me the difference in blood supply?
Dr. Abhay, can you wait for a
Yes,
moment?
sorry.
Kanagwell, I think you have to mute yourself.
Dr. Kanagavel.
Kanagwell, you have to mute yourself so that I can ask a question.
Kanagavel, can you please kindly mute yourself? I think he can't hear us. Kanna, please go on. I'll explain.
Somebody has to phone him up.
So ask your question, Dr. Khanna, so that we can.
Okay, I will ask him. I will ask her a question.
All right.
What is the difference in blood supply of superior thyroid artery to the thyroid as against inferior thyroid as given in McGregor, so that you can hear actually the bruit on the superior pole of the thyroid gland against
They are not audible.
Could you hear something, Dr. Kritika?
Sorry,
Please
someone.
something McGregor, where you can hear the. Dr. Abhay, can you repeat your question a little louder, please?
Yeah, I'll repeat my question. What is the difference between the superior thyroid artery supplying the gland as against the inferior thyroid artery as given in McGregor's surgical book of anatomy?
You mention what is the question?
The question is very simple. I'll give you the answer straight away, sir.
Please do
The
that.
superior thyroid artery supplies the gland, while inferior thyroid majorly supplies the capsule, and that's why in thyrotoxic patients you have superior thyroid giving you the bruit or whatever, and inferior thyroid being situated behind the gland and then coming up to the gland does not give you that bruit. That is the answer actually to a question which has been given in McGregor's textbook of anatomy.
Right. So, Dr. Khanna, your question you can ask now because Dr. Kanagavel's sound is.
Did you palpate the lymph nodes here?
Yes, sir.
Have
There
you
are no
mentioned
cervical
anywhere that?
lymphadenopathy. Yes, sir.
Did you
I
mention
mentioned.
anywhere about that?
Yes, sir. Yes,
Okay.
sir.
So which lymph nodes you are interested in a case of a thyroid swelling?
Thyroid swelling be the central group of lymph nodes, sir. And lateral group of lymph nodes, sir. Like initially it goes to the central group, sir. Then laterally it goes to the lateral groups of 2, 3, 4 jugular veins.
Right, if I may, Dr. Kiritika, what is central group actually?
Central groups are 3 tracheal, 3 laryngeal groups of lymph nodes, sir.
No. What are the boundaries? That's why, otherwise you would be all over the place. Which are these lymph nodes and can you palpate them actually? That is the question.
So they are not usually palpable, sir. Only
Excellent answer. Except for the prelaryngeal or the Delphian node. It is vein to vein, that is internal jugular vein on one side, internal jugular vein on the other side, hyoid bone above, and suprasternal notch below, which precisely is the region of the central compartment. But Delphian node, any idea where is it located? Which can be palpable?
The suprasternal notch.
No, it's pre-laryngeal. I'll answer that instantly so that we save on time. So other lymph nodes, lateral groups, which are the groups that are likely to be involved, which Professor Khanna was asking. Central compartment, yes, but not commonly palpable, mostly on ultrasound. Lateral groups, which are the levels?
Usually level 2, 3, and 4 groups can be found.
Yeah, it's unusual to find level 1 and level 5A. 5B can still be palpated. Do you know about 5A and 5B?
Okay, they belong to the posterior triangle group of lymph nodes.
Excellent. Divided by spinal accessory. So above is 5A, below is 5. So mostly it is confined to these. You mentioned about the bruit, correct?
Yes.
So when you're placing your stethoscope, most of us use the reverse side of it. But where do you actually place your stethoscope?
So along the anterior border of the sternocleidomastoid, across the upper border of the thyroid cartilage, sir.
I mean, I don't blame you because the length of superior thyroid artery is not so much that you will be able to isolate it from the external carotid artery. If you, for all those who dissect in that region, they will know it's very short. So you would not know whether you're hearing the bruit from the carotid or from the superior thyroid artery. And for right reasons, now these clinical signs don't hold that kind of a relevance. But theoretically, yes, it's important. And you described it almost correctly, but you cannot be sure. And some people like to auscultate it bang on the superior pole rather than going laterally away. So theory, there's a difference between theory and practice. When you practically see it, which most examiners would have seen, so that's why they'll ask you these questions. Any other question, Dr. I mean, I cannot see Dr. Sahai now. Dr. Sahai, you were asking something. Are you there?
No, I'm fine, sir. I'm fine. I
What are
think
the
most of it
various,
is discussed.
Dr. Khanna, you were asking something?
yeah, what are the various neurological signs you elicit in a case of a thyroid?
Neurological signs are we look for tremors, sir, in the hands. We ask the patient to outstretch the hands and both the upper limbs and the hands, and we generally place a paper over
No,
it to look for
don't just tell what are the, don't
uh,
describe the test, but just tell what are the various neurological signs you see in a patient with a thyroid.
and we also look for the fasciculations in the tongue, sir. We look
Yes,
for deep tendon reflexes, sir, and
yes.
also look for proximal muscle weakness, sir.
So
And
how do
eye
you check
signs
for the
like
proximal muscle weakness?
we'll ask the patient to stand from a squatting position, sir, and also to climb stairs, sir. If there's a
Okay.
proximal muscle weakness, they may have difficulty in performing this action.
All right. Okay. Thank you.
Thank you.
Now, what is this connection with deep reflexes that you find in thyrotoxicosis?
Reflexes are exaggerated in hyperthyroidism, sir, and they are sluggish in case of hypothyroidism, sir.
Yes, but why? So when we are having a clinical discussion, these things will be asked around. And you should also mention about the skin features. Which all eye signs you looked for? Can you rattle out quickly 1, 2, 3, 4? Otherwise, it will
The
sound
eye
like
signs
great.
of staring look as in Stelbach sign, sir, Von Graffi sign, Darlemper sign, uh, Darlem, and Geoffroy sign, sir.
You finish your answer, then I'll give you the final answer.
And next after almost can be seen what thought.
So
Lidlac sign, sir.
the purpose of this class is to also teach you how you should be putting it up. Making a dish is one part of it, serving it is another. That's what exam is all about. So always divide it into mild, moderate, and severe thyrotoxicosis. It will become easier for you. Not that it's always that way, right? So mild would be basic early signs. What are those? What is that stair sign
Lidlac,
called? Stairway, which you mentioned.
Stelbach.
How do you test for that?
Stelbach signs the staring look of the patient, sir.
What was my question? How do you test for that?
Asking the patient to see forward.
So you look in the patient's eyes at a distance of 30 to 40 centimeters. That's a specific way of doing a clinical sign exam. Okay? And then you wait for the blinking. Please don't provide answer before it is answered of psi. You can hold on for a while. I know it will be useful at the end. Otherwise, she's looking at it and will get confused. So eyeball to eyeball, who blinks first here? The normal person or the diseased person?
Normal person.
Very good. Then you have the other one is the Geoffroy sign. Patient is sitting, you're sitting in front. All signs are done in one go. How do you test for that? You mentioned it. I'm only asking how would you test for that?
Geoffroy is the absence of the forehead wrinkling.
How do you test for that, madam? That is correct.
Ask the patient to look up to the roof, sir. If there is no, there's the absence of the forehead wrinkling, positive.
So when you are doing it, you're also looking up, but what is happening is your head has moved. So the first part of the examination is to stabilize the head. And then you ask the patient to look up, only then you can expect the wrinkles to be present or to be absent. Now the moderate, Von Graffi's, what is that?
Von Grace is Lidlac sign, sir. So we ask the patient to follow
Again,
the.
fix the head. Again, fix the head. I'm stopping you there. Yeah. You
So
put
we
a,
ask the.
this is fixing, and now you can do the test. Yeah.
We have to fix the head and we have to ask the patient to follow fingers from moving it from upwards to downwards. And generally, the eyeball moves faster than the lid. Normally, both the eyeball and the lid comes together. But in case of in this case, there's a slight lag in the lid and the eyeball movement.
Excellent. Which was the next one? Mobius sign.
Mobius sign.
Yes, what is that, please?
So there is a lack of inability of the patient to converge. So we have to steady the head of the patient and bring a object initially from far and coming near. So there will be inability of the eyeballs to converge to look at the patient. So
Excellent. You
look at
mentioned
the
keeping the head, which is very important. And as you bring the object close, don't do it in a hurry, which is what a lot of people do. And the last one, a couple of them. What is the sign that you test when you turn the head backwards? What is that called? I won't give it a name. When you're looking for exophthalmos or proptosis.
figure sign.
Yes, very good. So how do you do that?
So we have to place the head of the patient around 180 and we have to go behind the patient and look for the supraciliary node. So if the proptosis is there, we can see the eyeball extending forward than the supraciliary node.
Cornea. We'll see the cornea. Right? Mild, moderate, severe, that's how the signs are all covered and it's straightforward. Any other question or comment before we move to the diagnosis and take it forward? Now let's go to the summary of your case and we can take it from there.
"48 years old lady, 5 cross 3 centimeter ovoid form, non-tender swelling in the right lobe of thyroid with smooth surface and well-defined border without any evidence of pressure symptoms or hyperthyroidism or hypothyroidism. Most probably a solitary nodule of thyroid from right lobe."
Now, always be loud and clear, as they call it, Lima Charlie. Whether the examiner is whatever, no examiner is ever wicked. Be clear on that head. Examiner is trying to find out what you know rather than what you don't know. And if he's in a hurry, he's trying to find out quickly how much do you know. Correct? So when you are speaking, be loud so that you are heard. Doesn't matter who the examiner is. Correct? So usually when you have to give a diagnosis, the summary is brilliantly done. They'll ask you more questions. Come to the diagnosis and then we'll open it up.
Diagnosis: this right solitary nodule of thyroid in euthyroid state, likely benign without any pressure symptoms.
Now, whenever you're giving diagnosis in thyroid disease and in a lot of other conditions, always mention the age and the gender. It has got a special significance in thyroid, right? So your lady is how old?
48 years.
So 48 years lady with a right-sided solitary thyroid nodule, clinically euthyroid, likely benign, without pressure symptoms. Did you learn something out of it or you got overwhelmed by what I spoke?
No, sir, I understood, sir.
This is how I teach and I've been doing it for a while. This is a very good diagnosis that you've given, which takes care of the anatomy, physiology, and the pathology. Age and gender. What is the significance in thyroid disorders, Dr. Kritika?
In case of malignancies, sir, the prognosis is good if the patient is less than 40 years of age, sir. And gender, females are more prone for thyroid disorders, sir, compared to males. So even if any swelling in case of male has got a poor prognosis compared to females.
Now, this used to be many years ago. Now, with the AJCC 8th edition, it has changed. So I'm correcting it and you remember it now. 55 is the cutoff. Okay? Less than 55, good prognosis. More than 55, bad prognosis. And less than 15 years also is bad prognosis. Younger patients also have an aggressive cancer. Will you remember that? One.
Yes, sir.
Second is gender. Females get it more often, but males get a worse cancer. They do badly with it. Correct? Which you said, but the age cutoff there changed. So don't ask me what happens to a patient who is 54 years and 11 months, because that will be 1 month short of becoming, so he'll delay his birthday. So that won't happen. So it is just a cutoff which they've created to basically prognosticate their cases. In every case, it doesn't work. Is that okay? Now, there are many questions which will come. I'll come back to you again. If now the question, this is open. Any question, Professor Khanna?
Any relevance of size of nodule? Will it have any impact on the prognosis and
4
management?
centimeter, 4 centimeters the cutoff is given for
Yeah.
papillary
Yeah.
carcinoma.
So maybe when you're making a diagnosis of solitary nodule here, even size can be added.
Okay. Sure.
All right. Any other comment or question?
What do you understand by quadruple testing?
Quadruple testing includes a history and general examinations, followed by high resolution ultrasound of the thyroid gland. And we perform a fine needle aspiration cytology, which is following the thyroid function test if it is normal, and genetic testing in relevant cases.
And what about the thyroid function test?
I think we'll come to that, Dr. Khanna, because the diagnosis is sorted. Any points here from anybody before we move to workup? Because quadruple test would be part of the workup. We'll come back.
When you are saying it's a solitary thyroid nodule, so that you are just telling the anatomical part, but you have to tell what is the cause for the solitary thyroid nodule. What are the common causes for the solitary thyroid nodule?
The differentials are thyroid cysts, then toxic adenoma, malignancy, and follicular neoplasm.
Why only toxic adenoma? Why you are saying toxic adenoma?
Any solitary swelling.
What do you understand by follicular neoplasms?
Follicular adenoma, so 10%.
So you better say it's a neoplasm, because you don't know that what is that. Clinically, you will not able to tell about that.
Therefore, Dr. Khanna and others, the diagnosis is solitary thyroid nodule. We'll investigate to find out. That's what they're suggesting. And maybe now you can be asked questions. So why is it, what is that solitary thyroid nodule? First of all, why is it a solitary thyroid nodule according to you? Forget about what caused it, but what is solitary thyroid nodule?
In the non-palpable gland, if only a single nodule is palpated, it's called a solitary nodule of thyroid.
If the gland is palpable and the nodule is also palpable, then it will be a multinodular. That's what you're saying?
Multinodular.
The concept of dominant nodule is no longer there. And secondly, why do you say it is clinically euthyroid? Now, these are the questions relating to your diagnosis. The rest is all theory. You can go back and read also. What is, why do you call it clinically euthyroid?
There is no symptoms suggestive of hyper or hypothyroidism and no signs which you to prove it.
So, beta, the answer is again to be given in a proper format. Otherwise, we are all over the place, points in history and points on examination. So, there are no points in history to suggest any of the features of thyrotoxicosis or hyperthyroidism, right? And on examination, there are no clinical signs to suggest it. So, we are out of it. Why do you think it is benign?
There are no, in history,
Please,
there is no.
as you just learned, as you learned, repeat it that way. Points in history and points on examination. We stick to a protocol in presentation. Otherwise, it's very vague. So what are the points in history that make you think it is benign?
Points in history is the slow-growing tumor, sir, and is not associated with any pressure symptoms or pain or infiltrative signs. There is no associated history of family history could causing leading to malignant condition. And in examination, there is no cervical lymphadenopathy, and there is swelling is firm and it is mobile, which rules out any infiltrative sign. And
you're right, but if you divide it properly, your answer becomes easier. And not all thyroid malignancies are hard, as you were asked about thyroid paradox in the beginning. So this happens here in the exam, right? So all cancers are not hard and many benign swellings are hard. So that's the paradox in thyroid. So don't just stick to that. So no, history of any rapid increase if we don't take it as a rapid increase. Okay. And as Dr. Khanna mentioned, sudden increase versus rapid. Please retain that. So you should be able to justify what you have mentioned. Now, when you have described it as a solitary thyroid nodule to the right side, in clinically euthyroid state, likely to be benign without pressure symptoms, I think we are more or less set for a solitary thyroid nodule discussion. And that becomes a very open chapter. I don't know how much time we have, but now you can come to how do you proceed? What do you do to any question, Dr. Ratna? Can we move?
Yeah, no, only one little thing. Can you tell us mobility in which direction would be suggestive of? If you find immobility in a thyroid swelling, in which direction would it be more significant to suggest that?
The up and down the movement.
Up and down.
Vertical
Why?
mobility.
Why?
So in case of infiltrative disorders, if there is an infiltration inside to the deep fascia,
Because
so there's
lateral
a
mobility may be maintained
minimal.
because trachea itself is mobile. If lateral mobility is also gone, it is frankly malignant. But if vertical mobility, which is intrinsic, is decreased, it is highly suggestive of infiltrative lesions. Yeah. Yes,
Right.
so that's it. Yeah.
So I think we got to wind up. We got a message. So how do you proceed now? You've already mentioned about the triple test and quadruple test. So to confirm the diagnosis,
investigation.
thyroid function test, high resolution ultrasound. Yeah, please, you carry on.
Investigations to confirm the diagnosis, thyroid function test, high resolution ultrasound of neck, and FNAC of thyroid nodule. So thyroid function test was done. That was normal.
I'll
High
give you a
resolution.
situation. I tell you, this becomes a very theoretical discussion. There is a thyroid spore. This is the case. Stop here. Thyroid spore, solid thyroid nodule, and there is no lymph node. Ultrasound is giving you thyroid spore. Bethesda 3. How do you manage this case?
So after thyroid spore is suspicious of malignancy, so we proceeded with FNAC, and though it came as
that has been done. That's how you know it is Bethesda 2, 3. No, I told you Bethesda 3. I'll
we'll
not
look for
please speak. Please carry on.
Bethesda 3. We will also do other investigations, X-ray of neck and video laryngoscopy.
Tell us what is the management. Forget about these workups. You know, it's all written on. You can read it, and it's not going to help anybody. Bethesda 3, which is suspicious. Thyroid 4, which again is suspicious. It is a disease confined to one side of the gland. What will be the next step? What is the most suggestive? What is the confirmatory diagnostic approach in thyroid swellings?
So we do have to, from the biopsy, we need to get a biopsy, so if it shows a...
How do you get a biopsy from thyroid gland?
No, so we have to classify according to the differentiated thyroid cancers or wholly differentiated thyroid malignancy.
Madam, it's not cancer. It is Bethesda 3 only. So what is the minimum biopsy in thyroid?
FNAC, sir.
FNAC is not a biopsy. Biopsy means you remove the tissue. FNAC is a cytology.
We do hemithyroidectomy, sir.
That's what I was asking you. Otherwise, you make me sound like doing an oration again. So I'm asking you a question, and asking a question, you have to repeat the question in multiple ways, no? So hemithyroidectomy is the bare minimum you want to say, all right? And based on that, you'll take a decision. That's what you're saying?
Yes, sir. Hemithyroidectomy has to be.
So hemithyroidectomy can then decide. If it is papillary?
So depending on the size, and if there is no other swellings, we can follow up the patient with the thyroglobulin, sir. And if it is more than 4 centimeter, and according to the prognostic criteria regarding the age, grade of the tumor, and the extra thyroid invasion and the size, we can go for either completion thyroidectomy, sir, or we follow up the patient with thyroglobulin 6 months.
It's not a bad answer, but if you put it down as we'll do risk stratification. In low risk, we can observe. In high risk, we'll do completion thyroidectomy. And their advantages and disadvantages, I think they're beyond the scope of a clinical class. And we should have stopped right at the diagnosis that you made, because the rest is all fairy. Everybody can read it. There's a lot of information available. Maybe another 3 minutes, everybody can ask one question each. Dr. Rajiv, any question of Sai? Dr. Khanna, I think I can see him. So,
Would
No,
you,
no, sir.
would you like to go for a hemithyroidectomy or total thyroidectomy in this patient? What will your
In
final
this
plan of
patient,
treatment?
we did procedure with total thyroidectomy, sir. And it came as thyroid follicular nodular disease with dominant hyperplastic nodules, sir.
Mhm. So why the total thyroidectomy was done?
So in this case, we had a larger nodules and also had another smaller nodule in the left lobe, sir. So in view of that, we proceeded clinically, though it was SNG, it came as in ultrasound came as MNG, sir. So we proceeded with total
so it is.
thyroidectomy.
So
What
then
is
MNG, no, then it is not solitary thyroid nodule because the diagnosis of there is no clinical diagnosis. It's based on ultrasound also, no. So
Ultrasound.
bilateral disease. That's what Professor Khanna is asking you. If it is one side only, why would you do a total? So what are you saying now? Ultrasound showed the nodule on the other side also.
Right, left side also, sir. So we proceeded, it considered as a multinodular goiter and proceeded with total thyroidectomy.
So what are the advantages of doing a total thyroidectomy in a benign condition?
So in case of a recurrence, if there is a recurrence or any smaller nodules in the other in the remaining thyroid, it may again proceeding with the surgery is difficult and may cause any nerve damage, sir. So doing a total thyroidectomy is beneficial, sir.
Thyrotoxicosis is very difficult to treat as compared to the hypo, because you can supplement it only by one tablet and that will take care. So that is why probably the concept of the total thyroidectomy is there.
Right.
Yeah.
So hemi versus total is a big debate even in cancer, but as mentioned, it is easier to manage hypo rather than recurring hyperthyroidism. And if you find something on hemithyroidectomy, you can proceed with, you can do a frozen, but frozen also has limitations. So you may have to do completion accordingly. So might as well do it completely. Any question, Dr. Ratna? Can we close?
I think we can move, sir. Thank you.
Thank you. Thank you very much, Dr. Kritika. Now I have a couple of things to tell you. Most of your presentation was right. And in these classes, unlike in the exam, I personally like to indulge more because we have to guide student into answering the correct way. If there is a wrong way, then that should be told the correct way also. It's not about you're not an examinee right now. I'm not your examiner. It's a class I'm teaching you. So all of them are teaching you. Forget about all that discussion. So basically, the purpose was that there should be a take home for you. If there is some take home, then you should be happy. That's the purpose of the class. We are not judging you. You've done well and you've done reasonably well for any postgraduate student. But did you note down the corrections? If you did not, maybe you can follow it up. Note down whatever you can make better in your presentation to make it even better. That's the purpose. Mediocrity is not a great idea ever. Well done. Thank you very much for your excellent presentation. I think everyone is very happy with the kind of presentation you made. Do you have any question to ask the examiners?
No, sir. Thank you.
You're again very soft. Be loud.
Thank you, sir. I don't have any.
Did you enjoy your presentation or you were feeling overwhelmed?
No, sir. I was enjoying it, sir.
Wonderful. Thank you very much. We enjoyed it too. So with that, we can close this presentation. If there's another case, maybe you can go ahead. Dr. Kanagavel.
Sir, I am with you. Maybe now we can give some time for Kritika to ask any doubts to be clarified. Then we can move on to the next.
I asked her, Dr. Kanagavel, I know your system.
Thank you.
Perfect. So
Anything more?
Questions, and she's super delighted at having presented. And with such illuminaries like Dr. Khanna being there, Dr. Sai, Dr. Ratna, all of these are seasoned teachers. So wonderful presentation. We thoroughly enjoyed it. And I hope you enjoyed it as much, which is more important. This is not an exam, I'm repeating, especially when I'm moderating. It's not an exam. Answer what you know. It's more important to share what you don't know here so that you learn it today and take home. Thank you.
Thank you.
Thank you, Dr. Kritika. Now we move on to Dr. Haridev. Haridev is presenting a case of epigastric mass here this evening. Haridev, can you switch on your video and start your presentation? Good luck to you, Haridev.
Not present here.
Kritika, you can stay back with us. Haridev, you are good to go, but I am yet to see your presentation.
Sir, the previous presentation has to be unshared for me to share my.
Kritika, can you do that, please?
Yes, sir. Yes, sir.
Good luck, Dr. Haridev.
Thank you, sir. Good evening to one and all present here. I am presenting a case of epigastric mass. I am Dr. Haridev, presenting under the guidance of Professor Naveen Alexander, sir, and HOD Professor C.D. Narayanan, sir. Sir, can I proceed, sir?
Please do. Thank you.
Yes. Mrs. X, a 63-year-old female who's a farmer by occupation, hailing from Maharani, came with chief complaints of upper abdominal pain for 20 days, yellowish discoloration of eyes for 20 days, and abdominal distension for 15 days. History of presenting illness. She complains of epigastric pain for 20 days. It was insidious in onset, gradually progressive, dull aching, intermittent, no radiation, no aggravating, no relieving factors. History of yellowish discoloration of eyes with eye-colored urine for 20 days. No history of any pale stools, generalized itching or disorientation, no waxing and waning of jaundice. Abdominal distension present for 15 days, generalized distension, gradually progressive, associated with loss of appetite for 20 days, history of constipation present for 20 days, which as she was passing flatus and hard stools, which were yellowish in color. There's history of non-quantifiable weight loss for 20 days, history of bilateral leg swelling, and there is no history of nausea, vomiting, early satiety, or dyspepsia, or any history of bowel rolling movements. There is no history of bleeding per rectum, no history of spurious diarrhea, no history of melena, hematemesis, no history of fever, breathlessness, palpitations, chest pain, cough with sputum, or decreased urine output, or periorbital edema. No history of any bleeding manifestations. Past medical history, no known comorbidities, no history of similar complaints in the past, no history of previous blood transfusion or tattooing or history of native medication use, no history of previous surgeries. She is married for 40 years. Obstetric history, para 1 live 1, normal vaginal delivery, attained menopause 10 years ago. No history of any bleeding per vaginum or white discharge per vaginum. Personal history, mixed diet, normal sleep habits, no history of any substance abuse, no history of jaundice in the family. Summary, a 63-year-old female with epigastric pain and abdominal distension with jaundice for the past 20 days.
Excellent. Wonderful history. And very loud. That's what is important, so that everybody has to listen. Half the time, if you're not able to hear, the questions won't come. 63 years old lady is a better term. Don't make it male, female. That's mostly for animals. With
Okay.
epigastric pain, abdominal distension, and jaundice for 20 days. Excellent. Now, any questions? Dr. Sai, Dr. Ratna, anybody?
God, please.
Dr. Ratna.
Yeah, go on,
Yeah.
Dr. Ratha, please.
You said pain is intermittent and dull aching. So based on the history, which organ or system do you think is involved?
Ma'am, probably the liver, ma'am, with jaundice and abdominal distension.
So why should the pain be intermittent in a patient with something which is starting in liver?
Yes, ma'am. In liver, probably it will be continuous, ma'am. But
Yeah. So could it be anything else which you may want to keep in your mind, which may not cause a very severe colic, but
All right.
biliary colic,
so
ma'am.
again, biliary colic could be a possibility. What about the progression of jaundice in your case?
Ma'am, it is static, ma'am. She said it was the same color as she noticed since the beginning of the jaundice.
So no, what is the color? Is it a high grade jaundice, or what is the color of urine or sclera?
Ma'am, urine is high colored, but sclera is mild yellowish in color, ma'am. Not orange color or very high grade.
Yeah,
right.
so
Yeah, please.
yes, so based on the color of urine, also you should be able to grade the jaundice.
Okay, ma'am.
Right, whether it is light yellow in color, mustard yellow, or is going towards the greenish side besides. So what do you think could be the reason for persistent jaundice with loss of appetite, loss of weight in a geriatric age group lady in whom you could be suspecting either a, continuous liver pain or a mild kind of a biliary colic? Do you think you're dealing with a benign pathology or a malignant pathology?
Ma'am, probably malignant, ma'am.
Yeah, okay. So,
Harideh, what is the
Yeah.
difference between waxing waning jaundice and intermittent jaundice?
Sir, in waxing and waning, there will be progressive increase and there will be again a decrease, sir. In the
Intermittent
intensity of the jaundice.
And what happens in the intermittent jaundice?
In intermittent, the jaundice will be absent for some time, again it will be present and will be absent for then sometimes.
To give the example of the intermittent jaundice and of the waxing waning jaundice.
Waxing and waning could be in any cholangiocarcinoma, sir, when there's sloughing of tumor cells. Intermittent jaundice, sir, probably passed out gallstone, sir, cholelithiasis.
Okay. Anything else which can give the intermittent jaundice?
Something simpler which you observe, and that's where it's classical.
Hepatitis, sir.
Oh, okay. Hepatitis doesn't produce intermittent jaundice, for God's sake. It is hepatitis. It is involving liver completely. Intermittent jaundice will only happen when the obstruction is intermittent. So think about it.
Sir, hemolysis, sir, hemolytic jaundice.
That's the problem with the ChatGPT and lots of Google. So don't watch anything when you're listening to a classroom.
So I'm not using anything else, sir.
No. I'm not talking about you. You read these things, this is what you'll do. Hemolysis will not produce that kind of a pattern. What about in the CBD stones? What is the jaundice like?
Sir, obstructive jaundice, sir.
I'm sorry, Dr. Khanna, I barged in, but I could not take it anymore. You can move on with that, right?
Like if
Okay, Dr. Haridev. So,
Yes,
somebody is staying in Kashmir, let me give an example of that.
He
What
doesn't.
can be the cause of intermittent jaundice there?
You
sir,
know,
probably oriental liver fluke, sir, clonorchis.
Clonorchis sinensis occurs in this part. That is Chinese liver fluke, no? So he's given you a hint, actually. I've given you a hint too. One is stone getting up, tumbling, obstructing off and on. Is there anything else? Have you heard of some parasites in the common bile duct? We have to move on. That's why I'm giving you a hint.
Sir, yes, sir, clonorchis, sir, liver fluke, sir, oriental liver fluke.
Ascariasis, है ना?
Oh, okay.
Ascariasis is one of the very common one, है ना?
Yes, sir.
Common things are common. Rare things are rare.
Okay.
Can you do you always have the urine yellow in jaundice?
Yes, sir.
What is acholic jaundice?
Yeah. Sir, not sure, sir.
Thank God.
What are the various types of jaundice?
Sir, pre-hepatic, hepatic, and post-hepatic, sir. Obstructive jaundice.
What is this pre-hepatic, post-hepatic jaundice? This is the first time I'm coming across pre-hepatic, hepatic, and post-hepatic jaundice. What is this?
Sir, pre-hepatic will be hemolysis, sir. And
what happens in that? In hemolytic jaundice, what happens to the urine?
Sir, it will be high colored, sir. Again.
Why the urine is yellow?
Sir, because of urobilinogen, sir.
Urobilinogen causes the urine yellow. That is absent in case of obstructive jaundice. In case of obstructive jaundice, the urobilinogen is usually absent. Once it starts appearing, it means it's a good sign.
Yes,
so it is not because of the urobilinogen. That yellow colored urine which is there, it is because of the bilirubin.
Yes, sir. Bilirubin. Yeah.
So in a case of the prehepatic jaundice or hemolytic jaundice, what type of the bilirubin is there? Let's say non-conjugated.
Yes, sir.
And a non-conjugated usually doesn't go through the urinary tract, through the glomeruli.
Yes, sir.
It's the
Is that
conjugated one which goes there.
Yes, sir.
Why, Dr. Hari?
Because it becomes water soluble, sir.
Okay.
Conjugated bilirubin is water soluble, hence it.
Glad you're thinking. That is good. Very, very important question and very nicely put. Any other question? or
Yeah,
comment?
Dr. Haridev.
Yes, sir.
Look, what's your differential biohistory?
No, okay, history. Yeah, I thought he jumped to the last.
Biohistory. No. What's the differential biohistory? What do you think is happening? There's pain, there's abdominal distension and jaundice for just 20 days in a fairly elderly lady.
Sir, probably liver will be the organ, sir. And
Why do you think it's liver?
because,
Abdominal distension in liver,
yes, sir,
unless the liver is very large.
with jaundice, sir. So generalized abdominal distension, probably ascites with jaundice, with epigastric pain, thinking in terms of livers.
Okay, anything else? You think it's a hepatic tumor? Okay, that's fine. Anything else?
No other symptoms are absent, sir. Like so that stomach and other organs are relatively
Why do you think it's absent? Why do you think it's absent? Can't be a stomach, a
It can
gastric
be
tumor
lower
with
down in the
secondaries.
differential, sir.
All right, points
Yes,
on your base.
let's have the differential. It may be low down or high up. Let's have the differential.
Only based on history, that's what you're asking. So we'll
Yeah.
come to that again. Let's move to examination, getting a notice
Okay.
of that.
Yeah.
We will come back to this question, Dr. Saab.
Yeah, no issues.
Let's move, Haridev, to
Yes, sir.
examination.
On examination, patient is conscious oriented, moderately built, moderately nourished, hydration is adequate, BMI of 28, ECOG score of 0, Karnofsky score of 80, icterus is present, bilateral pitting pedal edema is present, no pallor, no cyanosis, no clubbing, no generalized lymphadenopathy, left supraclavicular region is normal, no signs of liver cell failure, vitals pulse rate 70 beats per minute, BP 120/80 millimeters of mercury, saturation maintaining in room air, temperature is normal. This is the clinical picture, sir. And this is from the lateral view. And this is just the mark of the mass in the abdomen, sir. On inspection, abdomen is distended, flanks appear full, fullness noted in the epigastric region, umbilicus flush to skin, no visible gastric peristalsis, abdominal striae or stretch marks noted in the lower part of the abdomen, no scar, no sinuses seen, hernial orifices appear free, external genitalia normal, the mass appears less prominent on head raising. On palpation, no non-tender, abdomen is distended, no guarding, no rigidity, mass in the epigastric region extending to the right hypochondrium. The mass is vertically elongated, 9 × 6 centimeter length by breadth. It's a firm mass, nodular surface, irregular borders. Upper and lateral border of the mass is not palpable. Inferior and the medial border is palpable. Not able to insinuate the finger between the mass and the right hypochondrial, right costal margin. On palpation, the mass moves with respiration. The plane of the mass appears to be intra-abdominal and intraperitoneal. The spleen is not palpable. No renal angle tenderness. On percussion, shifting dullness is present. No fluid trill. Dull note noted over the mass, which is continuous with the liver dullness. Liver dullness felt at the 5th intercostal space. Liver span is 12 centimeter in the midclavicular line. On auscultation, it's normal. Per rectum, normal. Glove stained with yellow stools. No growth or nodules palpable. Per vaginal examination, again it's normal. Breast, thyroid and spine are normal. CVS, S1, S2 heard. No murmurs heard. RS, no added breath sounds. CNS, no focal neurological deficit. coming to summary, a 63-year-old lady with epigastric and right hypochondriac mass with distension of the abdomen, abdominal pain, jaundice, with a liver mass of 9 cross 6 centimeter, irregular firm mass. I would think in terms of a liver mass with ascites, probably liver secondaries with unknown primary, or a hepatocellular carcinoma. Sir?
Right. So, 63 years lady with epigastric and right hypochondrial mass with distension of abdomen, abdominal pain, jaundice, and mass 9 into 6 centimeter, irregular firm mass. That's your summary. What is your diagnosis?
Sir, secondaries, two differential diagnoses, sir. One, the more common one will be a liver secondary with an unknown primary. Another one will be an hepatocellular carcinoma. Sir.
So basically what you are palpating and what you have described so far is a liver.
Yes, sir.
And the liver has got a nodular surface.
Yes, sir. The mass is nodular, sir.
That's what I heard.
The liver is not palpable, sir. Only that mass is palpable, but resonance.
How do you know it is? How do you know it is liver?
Sir, not able to insinuate the finger between the right costal margin and the mass, sir.
Just
and the dullness is also similar to the liver dullness, sir. There is no band of resonance between the mass and the liver, sir.
Now, if you listen to me, my question is, how about the rest of the liver? Is that not palpable?
No, yes, sir, not palpable, sir.
So does that happen commonly?
No, sir.
So why should we think of uncommon thing today just because it is your birthday?
No, sir.
So what makes you think it is liver? Please justify. Just because it is continuous with liver dullness, it doesn't become liver.
Sir, associated with ascites and jaundice, sir.
No. Did you hear my question? That is what was happening in the previous case presentation also.
Most with the respiration, sir.
Dr. Sahai, the question has to be put.
Yeah, I say that you know the diagnosis. That's why you're saying it. I say this is a gallbladder, CA gallbladder. Prove me wrong.
Sir, gallbladder be more of a globular surface, sir, smooth.
Not necessary. Extensive malignancy, jaundice, ascites.
Dr. Haridev.
Yes, sir.
Life is too short to be learning only from your own mistakes. In the previous case, if you heard, I mentioned to the candidate, describe it as points in history and points in examination. You're here for learning.
Yes,
right?
sir.
You're not here for proving a point. If you already know the diagnosis, you're putting it the wrong way. It is possible to have exceptions, but clinically speaking, the liver in these conditions would be growing all along.
Yes, sir. Agreed, sir.
Just to have a nodule growing that large and the rest of the liver not even enlarging is not acceptable. Thirdly, as Dr. Sai mentioned very clearly, your lump is very much lying in the zone that he is referring to the condition. Why is it not that? He had to ask that question to make you understand the question. That is why the effort. This again, he is not delivering an oration. It's a question made better so that you understand. Are you understanding what he is asking?
Yes, sir. Yes, sir.
What did he ask you?
He's asking why it can't be another mass like a gallbladder carcinoma.
Why is it liver, sir? Firstly, why should it be liver? You said it's the mass is continuous with liver dullness. That is okay, acceptable. But there can be many masses which are lying adjacent to liver that would be continuous to with liver dullness. So why do you say it is liver? Let's start with the bottom line. Then the rest of the discussion can happen and all that theory can come in. You can go back and read. But why do you say it is liver first? Simple question.
Yes, sir. From history, sir, it's there is abdominal distension with jaundice, sir, and on examination.
No, look, Dr. Haridev, let me stop you here.
Yes, sir.
Look, just distension and jaundice doesn't make it liver.
Yes,
most
sir.
Liver masses don't have any kind of history like that, right?
Yes, sir.
They don't, right? So you
why liver mass would be distension? I was going to ask the same question,
sir.
So distension is usually a term used for either there is fluid or there is, they call it flatus, but gas distension, or there is blood. The mass will gradually grow, no? The distension is not the initial feature. Is there anything else in history? How long is your history?
Sir, it's a
20
short
days.
version of 20 days only, sir.
20
That's
days.
what the patient has noticed it, sir.
20 days history.
Yes, sir.
Jaundice. Abdominal distension is a part of the overall problem, which has happened in 20 days, whatever you're saying, 1 month or whatever. To have a liver mass, which is hepatocellular carcinoma, grow to that size in 1 month, even you don't want to believe it. That's
Yes.
why they're all asking you. Anyway, you have put up a case, so we will discuss it. Dr. Ratna, any questions?
Yeah, what can you describe the lower border of the liver? And is the mass separate from that, or is it continuous with the lower border
That he
of
said
liver?
it's continuous. Dr. Ratna, we'll cut it short.
Yeah. So is it rounded or is it a sharp border of liver?
Dr. Ratna, you probably didn't hear. The rest of the liver is not palpable. It's just that mass, right? So it is continuous with liver dullness. That's why he believes it's liver. Rest of the liver is not palpable. So you can't comment on the edge of the liver as a whole.
So that is strange actually, because normally the left lobe of the liver is palpable in epigastric area. And he should be able to tell us if it is continuous with that, or is left lobe also
He
not
is,
palpable? If left
Dr.
lobe is
Ratna,
not
he is.
palpable, it is hypertrophy
He-
atrophy complex.
This is called, Dr. Ratna, which we have seen in so many courses that we did together, scope included. They come prepared with a diagnosis and then they go backwards. And it hurts actually. Haridev, please mind. And now
Very true.
you're trying to stop.
So he is just assuming that there is a lump in the right lobe of the liver and that is it. And so probably again,
Dr.
palpatory
Sahab's
findings
point
need
is
to be
very
considered.
valid.
I just want to come in.
Very valid
Doctor,
that there is a mass there which is lying in the region where gallbladder would lie, as he said. And why is it not gallbladder? You couldn't answer that. You said it's continuous with liver dullness. That is also there. History, anything against it being a gallbladder? Let's answer that question first so that we can find some direction. Otherwise, now again the discussion would start. What are the types of this? What are the types of that? That you go back and read at home. Dr. Sai, you can take on.
Dr. Haridev.
Yes, sir.
There are couple of organs around.
Yes, sir.
Like you've got the pancreas, you've got the stomach, you've got the transverse colon, got the liver, the gallbladder, right?
Yes, sir.
You have to, by your history, rule out which of these organs may be involved or not involved, and what are these organs which can cause jaundice with pain and a lump.
Yes, sir.
You get me?
Yes, sir.
Yeah. So your history and examination should be doing that, but that's not come out with in your history and examination. Do you get me?
Yes, sir.
That's it.
Yes, Dr.
Sir, please.
Khanwekar, you're switched on, but there was discussion going on. Your questions, please, relating to the case. Thank you.
Dr. Hardev, can
Yes.
you tell what are the differential diagnosis of localized liver swelling? If you say it's a liver swelling is there,
Yes, sir.
why you are jumping directly over the malignancy here?
It could also be inflammatory like an inherited cyst, sir,
Yes.
or benign liver tumors, sir, like adenomas or focal nodular hyperplasia.
How long is your history, Haridev? Therefore, that Dr. Sai's point was very valid. You should be able to justify it with the history you're presenting. No? How long is your history?
Only 20 days, sir.
Please carry on.
So why it is not a mimic liver abscess?
Yes.
Yes, sir. Amoebic liver abscess is also possible, sir.
How
But there
long-
is no fever history, sir. But
Jaundice is there from the very beginning?
yes, sir. Jaundice is there from the beginnings.
And deep jaundice?
No, sir. Mild jaundice only, sir.
Please carry on, Professor Khan.
Yeah. No, I think probably once we get this type of the lump, probably the gallbladder will be probably the most important differential diagnosis. Okay.
Yes, sir. Gallbladder is.
अच्छा ये बड़ी अच्छी बात है कि आप सब कुछ प्रेजेंट ही ऐसा करो कि कुछ बन ही ना पाए तो अब बनाना ही पड़ेगा तो वही हो रहा है. You know, it's about a right hypochondrial mass which
Yes.
is gone onto the epigastrium, and you are giving a history of jaundice which is only 1 month old, 3 weeks. In gallbladder cancer, his jaundice is very late, you know, but it can be indolent for a long time. Patient did not notice it. Do you know why is it late in carcinoma? I have to discuss something, so I'm starting a window.
Yes.
Carcinoma gallbladder, why is jaundice not so early?
Sir, the growth has to grow and then compress on the hepatic duct to cause the jaundice, sir.
No,
You
no,
read.
Dr. Haridev. Does
Oh,
that growth
1
quickly
minute,
occur?
Dr. Sai,
What are
1
the
minute,
causes
1
of
minute.
jaundice in
I'm
CA
taking,
gallbladder?
please,
Yeah.
please, all of you. I'm
So
taking.
sorry. Sorry.
I'll hand him over to you only, but I'm taking
Yeah.
one road. That is what I was doing. It meant no oration here. Now, what he was saying was, I'm asking you a question, boss. Why is jaundice late in carcinoma gallbladder? You said it has to grow to reach the porta hepatis. So what did it open up? It opened up three, four things for me as an examiner. That you have not read about it. You read only about your liver, hepatocellular, and that's why you.
Or node when the gallbladder carcinoma metastasis to the porta hepatis node, it can compress and then cause the
So it is
jaundice.
a retrograde flow of lymph. So it will take at least 6 to 8 weeks before porta gets blocked, except when it is close to the porta. That is involving the neck of the gallbladder, which is the commonest site in carcinoma gallbladder to be involved. Professor Khanna's territory, but I'm asking you. Fundus, no?
Fundus.
So it is not commonly directly invading. So jaundice is not early unless you're giving us a wrong, completely cock and bull history and examination. That's what he was trying to say. When you think of a benign condition, you should be able to justify the benign condition. So your history should possibly take us there. Then you have to explain your ascites also. Yes or no?
Yes, sir.
So be careful about what you're saying. And now you are over to Professor Khanna. Please take on, Professor Khanna.
I was asking that what are the causes of jaundice in patient with the CA gallbladder?
He has answered that indirectly. Now,
No, one you said the porta hepatis, isn't it? There's a nodes of porta hepatis.
Yes.
secondly said was
What
a
are the
direct.
other causes of jaundice in CA gallbladder?
अभी तो बताया. Just now I told you direct infiltration is another. Tell the third one now. Two you have already said.
It can be pressing over that, है ना? Big lump pressing over the bile duct.
Yes, sir.
Okay.
Correct.
Can
Now,
it be choledocholithiasis?
Sir?
Can it occur because of choledocholithiasis in CA gallbladder?
Yes, sir. Could be, sir.
What is the chance of having the gallstone in a patient with CA gallbladder?
Very rare, sir.
very
Very
common. 90%. All right. So we'll kill the issue so that you don't take a lot of time. Dr. Sai, any question? I'll come back to Dr. Khanna. You are saying
No, it's okay. Please.
Dr. Khanna, please carry on.
Okay. So
So actually, he has put us in a spot, and
yeah.
now he's thoroughly enjoying it. So you tell us what is it? There is a 63-year lady with a very strange mass, which only affects one part of liver. Rest is fine. The rest of the liver is not even palpable, and it's not the left lobe that he's talking about. It's the right lobe, and there is ascites. He thinks it is malignancy, but he's probably misplacing the organ. Maybe we can take on from there. Is there any other organ which is a possibility? Gallbladder being one. All right, let's stick to what you have read. So you have written diagnosis in your slide also?
No, sir. I have not written the diagnosis, sir. I've
What is
just
your
mentioned.
diagnosis? Let's get your diagnosis finally.
Sir, shall I proceed, sir? Or?
You have to proceed, sir. Otherwise we'll be stuck.
Yes, sir. Sir, on investigation, the
No.
hemoglobin.
No investigation. Clinical only. So
Okay.
otherwise you have already got a diagnosis, which is what is a retrograde flow of information, and that is what confuses further. If you didn't know the diagnosis, what was your clinical impression? Forget about it, Haridev. You are a much better student than that. So what would have been your differential with a 63-year lady who developed a mass in the right hypochondrium? The rest of the liver is not palpable, and there are features of jaundice, which according to you is obstructive jaundice, and there is ascites, probably malignant. So what are the possible causes?
Sir, one would be gallbladder carcinoma, sir. Then, Or a liver carcinoma, sir. Gallbladder or liver carcinoma.
All right, Dr. Sahai, you were asking, please.
Yeah, look, sorry.
Yeah,
Okay,
please.
let's start with how will you manage this patient? Let's. I think you're just fumbling around with waste time. How will you manage? This patients come to your OPD,
Thank you for
20
that.
days
Yes, sir.
history, mass in epigastrium or hypochondrium with pain and jaundice. What
Yes,
do you
sir.
do?
Sir, an LFT, sir. To look if it is a direct elevation or an indirect
No,
elevation.
how will LFT just help you make your diagnosis?
Sir, a diagnosis ultrasound, sir. Ultrasound abdomen initially to.
Haridev,
So
for
you do
future,
your
Haridev, for
so
future, there should be some learning. Investigations to confirm the diagnosis, investigations to support the diagnosis, investigations to stage if it is a cancer, and investigations to treat the patient.
Yes,
This is
sir.
the right way to approach. Otherwise, we are all messed up. We could not discuss in the previous case, so at least in your case, we'll put it in perspective. What are the investigations to confirm the diagnosis?
CECT abdomen, sir.
So, have you heard of something less than a CECT?
An ultrasound abdomen.
What is the problem actually? You are working in a hospital where ultrasound would be done as an extension of clinical examination. Yes or no? Yes
Yes,
or no?
yes, sir.
That can ultrasound fix your issue?
Yes, sir. Ultrasound will help us know the organ of the pathology, sir.
Tell me more things that ultrasound will tell you.
It will tell us whether if there is any gallstones or intrahepatic biliary radical dilatations or any choledochos there. Then it can also help us tell about the ascites and any liver metastasis or any liver mass is there. Then
Okay. So it will tell you almost everything. Now
yes,
I'm telling you a situation. On ultrasound, it comes out to be carcinoma of the gallbladder, which Professor Khanna said, Dr. Sai said, and most of us agreed, with multiple metastasis to the liver, and there is one big metastasis which is probably what you're confusing with, and there is ascites. Would you still be doing a CT?
no, sir.
And what did you say earlier? I'll do a CT. Right? So we
Yes,
can keep it simple and safe, no? Simple and simple and simple. So don't complicate things because you know the diagnosis. That's why you're saying a lot of answers. In future, when you're presenting for your own good, Dr. Haridev,
yes,
don't
sir.
find out about the case. Otherwise, it becomes very easy for you. It becomes very easy for us also. We can keep talking about the theory of it, which is not the purpose of a clinical presentation. I'm sorry. So we didn't want to make you feel bad, but it doesn't make any sense to have just one nodule which is that large. It can happen, but it's not common. And the
Yes,
rest of the liver you didn't even mention is palpable. Otherwise, you can have liver which is enlarged, may not be as hard as this nodule, and this could be one nodule or couple of nodules that are merged together and they're giving a picture. Then you can have an unknown primary, which you mentioned. So therefore, let's not unnecessarily complicate simple things. Correct? Your
yes, sir.
history is short, maybe you didn't take it properly, or patient didn't give you properly. It is possible. So therefore, try to make it look like Dr. Sai was saying, your history and examination should be able to enlighten us with what you're saying. Otherwise, it doesn't make sense. No, now you want to say, I asked you what would confirm your diagnosis. You said CECT. Now, how would CECT confirm your diagnosis? The patient with jaundice may not have normal kidney function test. You may not be able even be able to do CECT. And I can see you're in scrub. So you work in the wards. So what do you do normally is what you do normally.
Yes,
Correct?
sir. Yes, sir.
Dr. Sai, Dr. Khanna, Dr. Ratna, please.
Can you tell me some liver tumors that may present as a hanging mass?
With jaundice, right? Dr. Ratna,
The
with
liver
jaundice.
tumors may be either of infiltrating type or
Or
pushing
pushing
type.
type or a
It
hanging
is the
type.
pushing type of a liver tumor which may attain a large size and may rarely present like this. And this, when it metastasizes to the other lobes, may present as a metastatic hepatocellular carcinoma. Is FNAC indicated in liver tumors?
No, ma'am.
Why?
Because we'll be spreading it to the skin and there's also chance of bleeding, ma'am.
Yeah, massive bleeding can be a reason. Very good. So,
Dr. Sahai, please. We have to make something out of it. So before we can.
Okay. Okay, let's you've done your ultrasound. Have you got the ultrasound report with you?
Yes, sir.
I've told this report
Can you
I've
put
told
it?
you.
Could you put it up?
Yes.
So what's so significant about it?
Sir, basically the liver is normal in size and there is multiple hyperechoic lesions seen in the both lobe of the liver with the largest of 4 cross 3.7 centimeter, and the mass is also the portal vein mass also appears to infiltrate the portal vein, sir, with crossing thrombosis.
So
Now, I think Dr. Sai, if we keep going on his
okay.
then probably we are
Yeah.
walking back here for us.
Okay. You've done the ultrasound. What after this?
Sir, we'll
Okay, what
proceed
is the immediate management of this patient? Forget investigation.
ascitic
What's the
tapping,
immediate
sir.
management? Huh?
Ascitic tapping and the LFT and CBC, sir, the basic investigation with ascitic tapping to relieve the
A patient of obstructive jaundice, how do you manage the patient, immediate management of the patient?
Dr. Sai, if I may, please.
So,
Now,
please.
I'll change the situation for just one moment. I
Yes.
find on it is a large hydrated cyst. Dr. Khanna was pointing towards it. We are looking at something. Why are you thinking it is malignant? You didn't give us any reason. Short history, yes. But suppose, let's make a case out of it. That also kind of presents as a hanging isolated mass. And we are discussing clinically. Okay.
yes, sir.
Can that present with jaundice along with a mass as we observed? Your phone.
No, sir, not my phone, sir.
You want to conclude? I didn't hear it.
Sir?
Haridev, answer that. No, you answer the question.
Sir, if it is if it is an hydrated cyst with associated with jaundice, we would just give an albendazole tablet
Sir,
and
no, sir. Oh. I asked you, is it possible first? Haridev, only diagnosis. Please go back, change the slide back. Don't
yes,
get.
sir.
Yeah, just stay where we are doing clinical. Yes.
Yes.
I am asking you, we could not discuss that. Professor Khanna mentioned also indirectly. One is liver abscess, you said short history. But hydrated cyst, can it produce jaundice also, obstructive jaundice?
Hydrated cyst, if it is compressing the biliary radicals.
Compression, next.
Yes, sir. Another thing is communicating with the biliary radicals, sir.
Oh, these are possibilities. If you get into a corner, don't have to make it malignancy because you already know the diagnosis. Now we are wasting time discussing what you have already done. So we want you to think better. If you have liver not being palpable in isolation, only that part is palpable, you have to justify that. Or your findings were not right because your ultrasound shows bilateral involvement of the liver. If liver is involved, you mentioned the liver span, how much?
The liver span
10 centimeters, I said.
Does your ultrasound say the size
Ultrasound.
of the liver? 18 centimeter or 16 centimeter.
liver span is 12 centimeters, sir. Ultrasound said 10 centimeters, sir.
Oh, sorry, the other way around. So what is the normal liver span?
Sir, normal liver span is up to 12 to 15, sir, maximum.
So the liver was not palpable, as you rightly said. So clinical finding was correct. Now, if you're facing such a case in the exam, Haridev,
yes, sir.
Don't be led by the diagnosis provided by any of your friends in the college who will come and tell you the diagnosis. You won't be able to justify it based on the history you have given us. You won't be able to justify it based on the examination that you have shown us. We only talk about what you presented, so that you won't have a diagnosis. So discuss those possibilities and discuss them, points in history, points on examination. I'm not saying it is hydrated cyst, but you can justify yourself by taking one after the other possibility. So this is one take home that I wanted everybody to, I don't know if you already know the diagnosis, how good is it to be presenting a case, because then you already are biased and you will try to fit, as they say, square picture into a round frame. That is what happened here. Dr. Sai told you in the very beginning, your history and examination should be able to lead us into thinking what you're saying. Dr. Khanna, you're quiet, so if you could speak now, please.
So I just want to put in a word.
What's that?
Dr. Haridev, the
Yes.
examination is not about arriving to a diagnosis, but how you reach the diagnosis. That is most important.
Yes, sir.
Coming to a diagnosis is not important,
Brilliant point. That's
right?
very, very
You get
important.
it?
That is
Yeah.
a take home for all students who are watching. And I think that's what confuses us when we already have a diagnosis and we start creating everything around it. You got a hint from Professor Khanna when he was there that it could be some benign. Why are you thinking about a malignant condition? You didn't justify any of those. You were already thinking about a diagnosis that you have. So I think most presentations should stop here and then the discussion should happen because these are clinical cases. Yes, Professor Khanna is there. Professor Khanna, your last few points and then we'll gradually close it.
Now, with this ultrasound finding, what was the diagnosis?
Sir, with the ultrasound finding, what is the diagnosis of this cases?
Don't go there. You speak now. Just speak. Don't read things. No,
Yes.
no point.
Sir, with the ultrasound findings, there are multiple liver masses, sir. So we'll be thinking of if it is any metastasis, sir. One.
If I say those masses which are there, they are the cholangitic abscesses are there. Patient is having jaundice with inflammatory mass, and you are thinking in terms of that it is a metastatic. I say it is not probably metastatic, it is multiple cholangitic abscesses are there.
Sir, counts were normal.
Hmm?
The total counts were normal, sir, for this patient.
So does that rule out that cholangitic abscess? Jay?
But no fever spikes, sir.
Okay, so that is a theoretical part you can discuss about that, Okay.
Because that's
So-
all you can discuss.
Yeah.
That's the problem. He has a diagnosis and now he is hell-bent upon discussing it. Come to your diagnosis, which you finally got by your investigations, including triple phase CT, everything. What was the diagnosis of this case?
Sir, hepatocellular carcinoma, sir.
There you are. It's all very easy to catch, actually, because when you started, you were hell-bent upon putting a square picture in a round frame, which I was telling. And you're smiling, I like it. So you understood your problem. Don't ever bother about diagnosis. Dr. Sai made a brilliant point. Take that one liner. It is not about making a diagnosis clinically. Nobody can. None of us makes a clinical diagnosis and treat a patient on that. All of us have to investigate. But your examination is about clinical examination, clinical science. It's not about those difficult syndromes and conditions that don't happen more frequently. It's about common sense surgery. How do you assess a lump in the right hypochondrium, which is going up to the epigastrium, with a history which is suggestive of jaundice being there, with a short history in an elderly person? I won't call 63 elderly anymore. So basically, we are looking at how do you proceed. Not about diagnosis. Who cares for what diagnosis you make? Based on your diagnosis or even my clinical diagnosis, nobody's treated these days. But this exam is about clinical examination. All
Yes.
right? And
Yes.
not about those very, very rare situations which don't happen. So understand it's about common sense. Most examiners who do that regularly or who are teaching regularly teach with common sense only. That's what everybody was trying to suggest to you.
Yes.
Now, with this diagnosis, since you have prepared it all, I think it will take us less time. How are you going to manage this case?
Sir, we'll first assess the child book score, sir, for the patient. And the size of the tumor is also more than 5 centimeter, and there are multiple nodules, sir. And it's infiltrating the portal vein. So I would like to give sorafenib, sir, for...
Have you confirmed your diagnosis?
Please. You're jumping the gun, Haridev.
Dr. Khanna put the nail on the head.
Sir,
I don't agree with your diagnosis.
sir,
Are there some tumor markers? How do you decide it's a base
sir,
malignancy? Just
tumor markers,
because
yes, sir.
your
Tumor
CT
markers.
has told you.
Tumor markers we have to do, sir. Alpha fetoprotein. We'll have to do, sir. Alpha fetoprotein has to be done, sir.
That's
Very
it.
good. You're very hardworking
That's it.
resident in the world.
CA99 and CEA, sir. Other tumor markers also.
Yet it's 10 o'clock. You're a very hardworking resident. You prepared the case well, all the investigations that were done, you put them down, and then you created your clinical history and your examination. Don't do it. The surest recipe to failure is to know the diagnosis, friend. And people would be nice to you, but that is not how it works out. You are a very good, very intelligent student. I can see that your smile says it all. You understood your problem. We are not discussing it as Professor Khanna said, it's all theory. You can keep reading around it. You'll spend your lifetime reading about it. If I managed a case of the similar nature last week, it is not by the technique that I learned 10 years ago, 50. It keeps changing. What we are examining here, what we are looking at you is for the clinical history and examination and nothing beyond it. So, Dr. Ratna, any question? I think I was going to end it with Professor Khanna, but then if there is anything you want to say, we'll conclude it here. Otherwise, do you have anything to ask, Dr. Haridev? Please ask honestly. Were we nasty to you?
Sir, no, sir. Sir, but the examination findings were all like the patient's examination findings only, sir. And probably, as you said, sir, with the history and examination, gallbladder mass would be the first suspicion, then probably the liver mass, sir. Then,
Brilliant.
Dr. Haridev, Dr. Haridev,
yes,
just
sir.
because we're saying that you don't look, the most commonly is you can't have a normal liver with such a thing, right? It's very rare.
Yes, sir.
And hepatocellular carcinoma is way down in commonality.
So,
Okay.
Haridev, you said something very good here, that you put gallbladder up and then you will possibly put some metastasis also.
Metastasis a second, sir.
And you're very intelligent. What is the other take home from this presentation? We would like to get a feedback from you also, so that we also improve.
Sir, take home from this one would be like only based on the history and examination, the whatever it has to fit into the diagnosis, sir, to the differential diagnosis. So that is one.
If you have understood this, Haridev, that is more than enough.
Yes.
Knowing a diagnosis, I can give you hundreds of examples where the patient got changed and the examination happened, and during examination, the candidate is so puzzled, he presented the wrong case as something else. So don't be led by somebody giving you a diagnosis. And investigations happen only later. So your clinical diagnosis is what the presentation was about. And you made a brave effort to defend something which is unusual. I must agree with you that although the diagnosis is hepatocellular carcinoma, taking into account the hanging tumors and the compressing tumors, it still would be considered a rare possibility. You will appreciate that.
Yes,
because
sir.
you can see that the entire liver should have enlarged a little bit.
Yes, sir.
Your clinical findings were right, but it was not arriving anywhere. So don't have to give a diagnosis.
Yes, sir.
Now I am coming to the way you should do it, and don't take it as an oration, please. You would have discussed it as a patient who is 63-year-old, a case of obstructive jaundice with an epigastric right hypochondrial mass and distension, likely to be malignant, and I have this differential diagnosis. I'll discuss. Your
Yes.
exam is through. So that then questions would start. Why do you think it is obstructive jaundice? Which is the likely possibility? Why do you think it is a malignancy? Can it be a benign condition? What is the relevance of intermittent and you heard about that from Professor Khanna. These questions would come automatically. And by the time your diagnosis is asked, you've already given a vague answer because it is vague. It's not your fault. But how to deal with it in an exam if you have a case like this is don't know the diagnosis, you'll do a much better job. Just discuss it as a lump, which probably is arising from liver, other possibly gallbladder, or maybe liver only, but unusual. And it could be stomach, as Dr. Sai tried to drag you into, but then give reasons why it is not this. And then come towards the end to maybe even hepatocellular carcinoma, but it's not common. The rest of the liver would also be generally palpable or enlarged. And you're done. Nobody is going to fail you for that. And for giving a diagnosis, nobody is going to pass you, especially in this case, because then the whole story gets opened up. Right?
Yes,
so,
sir.
Anything else you want to ask us before we conclude?
No, sir. I understood like the way you told, sir. So that way of presentation would have been a better than liver mass. Yeah.
Thank you so much. And Professor Khanna, it's such a delight seeing you after such a long time. Thank you very much for tolerating the time.
Thank you.
Thank you.
Thank you very much for joining this. I have been there always for last 2-3 years now.
I know that is
Yeah,
what
yeah,
makes it
yeah.
special. Dr. Sai, thank you very much. Dr. Ratna,
Thank you, sir. Your classes are always a pleasure. Always, we always look forward to it.
thank you so much. Mine pleasure is all mine. I learned from.
Thank you very much, sir.
Thank you, Dr. Kanagewal. Thank you, Dr. Haridev, for making it special for us. It's 10 o'clock, and I'm sure you enjoyed it as much as we did. Did you enjoy it?
Yes, sir. Yes, sir. Definitely, sir.
Great.
Thank you very much, sir. Thank you.
Dr. Kanagewal.
My network is down. Thank you very much, sir. We look forward to have you soon on our board.
Great. Thank you so
Right,
much.
good night, everyone.
Thank you so
Good
much.
night.
Thank you, Dr. Hari. Give my thanks to Dr. Naveen, sir, and all the faculty there at TDN, sir, and Balaji, sir. Good luck.